Hello, good morning and good afternoon for some. Welcome to our sickle cell data collection program for California's webinar series. My name is Niani Coker and I am from Tracking California's SCDC program, and I will be today's moderator. We have a great webinar planned for you today focused on COVID-19 outcomes among individuals with sickle cell disease. I'd like to introduce today's speaker, Ashima Singh. Ashima Singh, MS, PhD, is an assistant professor in the Department of Pediatrics at the Medical College of Wisconsin. Dr. Singh's current work involves leveraging the big data of electronic health records and administrative claims to understand healthcare service utilization and clinical outcomes for the sickle cell disease population. These data allow a research continuum that includes treatment and diagnoses, risk assessment and prediction, and disparities in epidemiology. In addition, she is interested in patient-reported outcomes for children with sickle cell disease that complement clinical outcomes. She is currently leading the statewide surveillance program in Wisconsin for individuals with SCD that is funded by the Centers for Disease Control and Prevention and serves as a co-investigator for ongoing studies funded by the NIH to understand biomarkers for pain among individuals with sickle cell disease. Okay, and so with that, I will turn it over to you, Ashima.
Thank you so much, Niani, for that kind introduction. I'm truly honored to be here to present here on this platform and talk about our work. Today, as Niani mentioned, I'll be talking about COVID-19 outcomes among individuals with sickle cell disease. Next slide, please. So before I get into the talk, just a quick outline and objectives of the presentation today. I basically will be talking about 3 studies related to COVID-19 and sickle cell disease that we have been that we've done in the past couple of years to understand the impact of COVID-19 for the population, for this vulnerable population. Our first study looks at COVID-19 outcomes among individuals with sickle cell disease compared to those who do not have sickle cell disease or trait. The second study that we'll be talking about investigates the risk of venous thromboembolism among individuals with sickle cell disease and COVID-19. And finally, we'll describe the risk factors for severe COVID-19 illness among individuals with sickle cell disease. Next slide, please. Sickle cell disease, as you already know, is a genetic disease caused by mutation in the beta chain of hemoglobin gene. There are approximately 100,000 individuals living with sickle cell disease in the United States of America, and these individuals have high rates of acute care utilization, most commonly for pain. And also, I wanted to specify that individuals with sickle cell disease population in this country is predominantly Black, who are victims of interpersonal, structural, and systemic racism, and imagine having a chronic condition on top of that. Next slide, please. This painting is a famous one by Hertz Nazar, who was a renowned artist, a sickle cell disease advocate, and a sickle cell disease warrior himself. As the painting is named 10 Redefined, reflecting that individuals with sickle cell disease experience such pain that cannot be captured in the pain scale of 1 to 10. And it's not just pain. Individuals with sickle cell disease are at risk of several acute and chronic complications. Sickle cell disease can impact almost any organ system in the human body. Next slide, please. So how does COVID-19 impact individuals with sickle cell disease? COVID-19 is caused by the SARS-CoV-2 virus, and the first COVID-19 case in the US was identified in January 2020. And at that time, the COVID-19 was, the virus and the disease was novel, and there was a need to generate rapid information on the impact of COVID-19 on general population as well as vulnerable populations such as the sickle cell disease. So we leveraged electronic health record data and created a registry to understand the impact of COVID-19 among individuals with sickle cell disease. Next. Electronic health record data, just briefly describe what this is, because in the recent times I've come to realize that this terminology is used in slightly different ways by different people. So EHR data is collected every time any patient has an encounter with a healthcare system. These data are collected for billing purposes and not research. But they have great power, because imagine having longitudinal data for encounters over time for multiple individuals across multiple institutions, and together they form big data that can inform population health. And the definition of big data are that they have volume, that's very large amounts of data. Variety can include structured and unstructured data. Velocity, these data created at a rapid pace and with proper infrastructure can be analyzed in near real time. And veracity, that these data, because they're not collected for research, the primary purpose is not research, they may not be fully accurate, and thus a lot of cleaning and cleaning is needed before we can use them for research. Next slide, please. So coming to our first question, are individuals with sickle cell disease at risk of worse COVID-19 outcomes compared to those who do not have sickle cell disease or trait? Next. So at the time that we were doing this study, there were publications that were coming out that showed that individuals with pre-existing conditions are at a higher risk of severe illness and death due to COVID-19. These pre-existing conditions included hypertension, cardiovascular disease, diabetes, acute organ dysfunction, obesity, and cancer. But there was no knowledge of whether sickle cell disease increases the risk of severe illness and death due to COVID-19. So our objective was to compare COVID-19 outcomes among individuals with sickle cell disease to Blacks who do not have sickle cell disease or trait. Our hypothesis being that individuals with sickle cell disease are at a higher risk of severe COVID-19 illness and death compared to Blacks who do not have sickle cell disease or trait. So to answer this question, we leveraged data from TriNetX. TriNetX is a research network that includes electronic health record data from more than 30 sites across the country. It includes de-identified patient-level data, which are refreshed on a regular basis. This network has a HIPAA-compliant platform with built-for-purpose user interface and analytics capability, which makes it really convenient for assessing the feasibility of studies and as such. So for this study, we identified two distinct COVID-19 patient cohorts and excluded individuals with sickle cell who had any diagnosis of sickle cell trait. Sickle cell trait occurs among individuals who have one sickle cell gene and one normal gene. And these individuals do not have sickle cell disease. So we wanted to keep our cohort of interest in the comparison group as clean as possible. So a first cohort included COVID-19 patients who were Black and had sickle cell disease. Identification of sickle cell disease was based on ICD code associated with an ambulatory or inpatient visit. Our comparator group included COVID-19 patients who were Black but did not have sickle cell disease or trait. For our outcomes, we looked at COVID-19 manifestations within 2 weeks of diagnosis. The COVID-19 manifestations that we looked at were cough, fever, pneumonia, acute chest syndrome, pain, shortness of breath or hypoxia, acute respiratory distress or failure. And we also looked at hospitalization and death within 2 weeks and 30 days of COVID-19 diagnosis. Next, please. To do the statistical analysis, we use t-test and z-test to compare demographic and pre-existing comorbidities between groups. And as I show in my next slide, I think there were differences. There were certainly large differences in the demographic and pre-existing comorbidities. So we used 1:1 propensity score matching to balance the characteristics between groups to determine the impact of having sickle cell disease on COVID-19 outcomes. And then after matching, calculated risk ratios with 95% confidence interval. And because we wanted to look at, sorry, go back to the previous slide. Thank you. Because we wanted to looking at multiple outcomes, we a priori determined a more stringent p-value of 0.01 to determine if there were significant differences or not. Next slide. This slide shows the demographic and clinical characteristics of the study population. There were 312 sickle cell disease, the COVID-19 patients who had sickle cell disease, and there were more than 45,000 COVID-19 patients who did not have any any diagnosis of sickle cell disease or trait in the available data. And as you can see by the bolded p-values and with orange arrows next to them, there were significant differences between the two groups. Can you please hit next one time? Yeah, thank you. Sickle cell disease compared to Blacks without sickle cell disease or trait were significantly younger. A higher proportion of them had asthma, diabetes, a history of acute kidney failure, chronic kidney disease, a history of liver conditions, cerebral infarcts, and pulmonary embolism and VTE prior to COVID-19. Next. So we matched for those baseline characteristics, and after matching, we found that patients with sickle cell disease had a significantly higher risk of experiencing pain and pneumonia or acute chest syndrome due to COVID-19. They were also at a significantly higher risk of being hospitalized, irrespective of whether we looked at hospitalization within 14 days or 30 days. So this risk was significantly higher compared to those who did not have sickle cell disease. Can you please hit just next ones? Yeah. And interestingly, there were no significant differences in mortality between as the sickle cell disease group and the group that did not have sickle cell disease after matching for the demographic and clinical characteristics. Next. So to conclude this study, when we compared COVID-19 outcomes for patients with sickle cell disease with Blacks who did not have sickle cell disease or trait, matching for age, gender, and clinical comorbidities, we found the sickle cell disease patients have a significantly higher rate of hospitalization, a higher rate of pain, pneumonia, acute chest syndrome, and a higher rate of pain. But there were no significant differences in mortality observed. Next. So our second question, coming to our second question, was does COVID-19 increase the risk of thromboembolism for individuals with sickle cell disease? Next. The illustration on the left shows that individuals with sickle cell disease have high incidence of venous thromboembolism or VTE. VTE in sickle cell disease is also has a very high recurrence rate. Prior publications have shown that it's almost 24% over the 5 years. And independently, VTE is a severe complication among patients with COVID-19. In fact, it's so severe that mortality rate is 74% higher among COVID-19 patients who develop thromboembolism compared to those who do not. but it was unknown if within the sickle cell disease population, if COVID-19 infection increases the already high risk of VTE. Next, please. So the objective of this study was to compare VTE rates between sickle cell disease patients hospitalized with COVID-19 and sickle cell disease patients hospitalized but who did not have COVID-19. We hypothesized that VTE rates among the sickle cell disease patients with COVID-19 would be higher than the sickle cell disease patients without COVID-19. We used the same TriNetX research network data that includes EHR data from multiple sites. But for this study, we restricted our population to the hospitalized sickle cell disease patients in year 2020. And so, very similar to the prior study, sickle cell disease patients were identified using associated sickle cell disease ICD codes with that were associated with an ambulatory or inpatient visit, and excluded patients who had a diagnosis of trade to increase the specificity of a cohort. We identified two groups in this study. One was sickle cell disease patients hospitalized with COVID-19, and COVID-19 was identified by the presence of COVID-19 ICD code or a positive COVID-19 test. And patients were considered to be hospitalized with COVID-19 if hospitalization occurred within 14 days of COVID-19 diagnosis. Our comparator group was sickle cell disease patients who were hospitalized in year 2020 but did not have COVID-19. And we excluded, from this group, we excluded patients who could have had COVID-19 anytime before or after the index event. Our outcome of interest, as I've been saying for this study, is VTE, which included deep vein thrombosis and pulmonary embolism. And we looked at VTE at within 30 days of index event, within 90 days of index event, and within 180 days of index event. The demographic and clinical characteristics between the two defined groups were compared using t-test or chi-square test. We used Poisson regression models with log-link and robust error variance to estimate relative risk and 95% confidence interval. And each of the VTE outcomes within 1 month, 3 months, and 6 months were modeled separately. This table shows that we identified 281 sickle cell disease patients who were hospitalized with COVID-19, and there were 4,873 sickle cell disease patients who were hospitalized but did not have COVID-19. There were significant differences between these two groups. Next. So patients with sickle cell disease hospitalized with COVID-19 compared to those without COVID-19 were significantly older. A higher proportion of them had a history of hypertension, acute or chronic kidney disease, obesity, and prior VTE. Next. So the results, I did not put the parameter estimates for our model because these data are under review for our publication, but just wanted to share what we found. Contrary to our hypothesis, we found that there were no significant differences in VTE rates between sickle cell disease individuals with COVID-19 and those who did not have COVID-19. And this stayed true whether we looked at 30 days, 90 days, whether we looked at VTE within 30 days, within 90 days, or 180 days. And reassuringly, in our model, we found that the factors that are known to be associated with an increased VTE risk for the sickle cell disease population, such as the age, obesity to some extent, prior history of VTE and pulmonary embolism, and prior history of acute and chronic kidney disease, were significantly associated with a higher risk of VTE. So our study suggested that immunothrombosis due to COVID-19 in individuals with sickle cell disease does not exacerbate the known underlying VTE risk for the sickle cell disease population. But we recognize that there's future work that's needed to investigate the use of anticoagulants for COVID-19 patients with sickle cell disease and see how that impacts their outcome. Now coming to the last study that I would like to talk about today. What are the risk factors for severe COVID-19 illness among patients with sickle cell disease? And for this study, we used data from Secure Sickle Cell Disease Registry. And just a little background on the origin of Secure Sickle Cell Disease Registry. As I mentioned earlier, when SARS-CoV-2 came to be known, there was a critical need to understand the impact of new virus on individuals with sickle cell disease. And under the leadership of Dr. Julie Penapinto and Dr. Amanda Brando, Dr. Julie Penapinto, we set up this registry. Dr. Julie Penapinto was at MCW at that time and has transitioned to NIH since then. And Dr. Amanda Brando is a pediatric hematologist at MCW. So under their leadership, we realized that there's a power in collective reporting in near real time. So we created this registry in a fast mode, and it went live mid-March 2020, right around the time when WHO declared COVID-19 as a pandemic. It's modeled after a similar registry for inflammatory bowel disease. Next. The goals of this registry are to report outcomes of COVID-19 illness among individuals with sickle cell disease. We wanted to quickly identify cases and share broadly. It is truly a national and international effort, so thank you to all who have reported to this registry. This registry could not have been possible without everyone's support. The data included in this registry are de-identified, and we do not include any protected health information. And the findings in aggregate are posted on website, mainly with the intention of sharing information with multiple stakeholders, including patients, families, and providers. And the link to the website could be seen in the previous slide. Thank you. Next. A snapshot of how the registry has evolved since its inception. We've had 590 pediatric sickle cell disease and COVID-19 is sickle cell disease patients with sickle cell disease and COVID-19 cases reported to our registry, and there are 455 adults with COVID-19 and sickle cell disease that are reported on that platform. And as you can see on this graph, over time, as we learned more about COVID-19, as new tools were available to manage and prevent COVID-19, our registry has evolved, and we continue to collect data. Next, please. The severity of reported COVID-19 cases in our registry show that there is a variable presentation, a variable COVID-19 presentation within the sickle cell disease population. the blue, blue highlighted in this pie chart shows that 16% of the reported cases were asymptomatic, 60% mild, and the remaining were moderate, severe, or critical. Next, please. So the background of the work that I'm going to describe in the next few slides. The data from Secure Sickle Cell Disease Registry showed variable COVID-19 presentation among individuals with sickle cell disease. Our prior work that I spoke about showed individuals with sickle cell disease have higher rates of hospitalization, pain, and pneumonia compared to the general population. However, the question remained if there are certain patient characteristics within the sickle cell disease population that put these individuals at risk of severe COVID-19 illness. Next. So the objective was to identify factors associated with hospitalization and serious COVID-19 illness in patients with sickle cell disease. We hypothesized that sickle cell disease-related comorbidities would be associated with hospitalization and serious COVID-19 illness. In this study, we included cases that were reported starting March 2020 through March 2021. And as you can see on the map on the left, there were a large proportion of the cases were from United States, but there were cases reported from multiple countries. And to keep our cohort clean, we excluded cases that were missing required data for confirmation of legitimacy of reports, like the name, email address, and institution of the reporter and the provider, just so that we know that what we are capturing, for the cases that we are capturing, we have the required all the required information available. Next, our outcomes for which we wanted to look at risk factors included hospitalization due to COVID-19 and serious COVID-19 illness. Serious COVID-19 illness is defined as if the individuals had pneumonia, early respiratory symptoms or gastrointestinal symptoms that were followed by dyspnea or hypoxia, acute respiratory distress syndrome, respiratory failure, encephalopathy, shock, coagulopathy, multi-organ impairment due to COVID-19 that could be life-threatening. We use generalized linear models with log linked to obtain relative risk with 95% confidence interval. And our multivariable models included covariates of age, sex, genotype, use of hydroxyurea, and sickle cell disease related and non-related comorbidities. Looking at the demographic characteristics of the cases in our study, there were 364 children with sickle cell disease that were included and 386 adults. Looking at the demographics of children, the median age was 11 years. Right about 50% were females, as expected, majority Blacks. 5.5% were Hispanic or Latino, and 72% had sickle cell anemia. The adults, so can you please go back? The median age for adults was 31 years. A little more than 50% were females, 57% were females. Again, majority Blacks, 9% Hispanic or Latino, and 68% had sickle cell anemia. Next, please. So the results and conclusion from this study, and this is a busy figure, but we really like it because it gives a lot of information in a succinct way, and I'll walk you through it. But before I talk about this figure, I just wanted to acknowledge Dr. Lana Muzzalo, who is a postdoc in our lab, who actually led this study and created this visual abstract. So thank you, Dr. Muzzalo. Looking at the risk factors, in the green, in the green shaded area, we describe the risk factors for either hospitalization or severe COVID-19 illness for children. And the peach risk factor and the risk factors listed in the peach highlighted area are those for adults. So first, looking at risk factors for hospitalization for children. We found that sickle cell disease related heart and lung comorbidities and history of pain were significant risk factors for hospitalization due to COVID-19 for children with sickle cell disease. And for adults, it was just the history of pain that was a significant risk factor for hospitalization due to COVID-19. On the right-hand side, the risk factors for serious COVID-19 illness are illustrated. For children with sickle cell disease related heart and lung comorbidities, sickle cell disease related renal comorbidities, and history of pain were significant risk factors for severe COVID-19 illness. And similar to that for hospitalization for adults, risk factors for hospitalization for adults, risk factors for severe COVID-19 illness were just the history of pain. Next, please. So to summarize this presentation, I described 3 studies, and we found that individuals with sickle cell disease and COVID-19 have higher rates of hospitalization, pneumonia, and pain compared to COVID-19 patients who do not have a sickle cell disease. COVID-19 does not appear to increase the already exacerbated risk of VTE among individuals with sickle cell disease. And the risk factors for severe COVID-19 illness for children with sickle cell disease include sickle cell disease related renal comorbidities, sickle cell disease related heart and lung comorbidities, and history of pain. Whereas for adults, we found that history of pain was the only risk factor for severe COVID-19 illness for adults with sickle cell disease. Next, please. And finally, I would thank you all for your attention and really wanted to acknowledge everybody on the slide who has helped with this work and continue to help with the ongoing work. And especially I'm grateful for my mentors, Dr. Julie Penipento when she was at MCW, Dr. Amanda Brando, and Dr. David Pruso, who continue to mentor me, and Dr. Aaron Shade, who have collaborated with on studies related to VTE. Our statistical team, Mawa and Dr. Simpson, the CTSI team, who really does the heavy lifting of maintaining these research network database and REDCap databases for our registry, Chris Osinski and Brad Taylor. And of course, our very loved sickle cell research team who help significantly with the work that I presented today and continue to help for the ongoing work. And that's it. I'll stop talking and we'll be happy to take any questions.
Wonderful. Thank you so much, Ashima. That presentation was so informative, and I'm sure there will be many questions. At this time, I want to remind everyone that we take questions through the chat box or question function on the control panel feature of this webinar. So I will turn it over to Susan to start the Q&A.
Thank you so much. This was really, really interesting. I have been eager to hear in particular about results coming out of the Secure SCD registry. And so it was really exciting to get a glimpse into that. Some questions are starting to come in. I'm going to give that just a minute. Thanks, folks, for putting those in the question box. And I'm going to start with a couple of questions that I have based on your talk. So for the first two studies, which were based on existing data, sounds like EHR or claims data, can you just clarify how you defined whether someone had sickle cell or not? I know you said based on SCD on ICD codes, but was there a particular case definition or just any mention of SCD in any of their ICD codes?
Yeah, thank you for that question, Susan. So we at our site have created and validated an algorithm to identify sickle cell disease, individuals with sickle cell disease within the EHR data, and we adopted that algorithm, the way it defines identifies sickle cell disease individuals is if there is an inpatient visit associated with a diagnosis of sickle cell disease or an ambulatory visit associated with a sickle cell disease, then we include that patient, and then on top of that, we exclude from that cohort, we exclude anybody who has an ICD diagnosis of sickle cell trait that could be anywhere in their EHR data.
Okay, that's really helpful. Thank you. And the second question is in the registry data that you talked about. Can you say a little bit more? I know history of pain was one of the variables, but can you say a little bit more how that was defined? That seems like it would be almost ubiquitous in the population. So I was a little unsure how to interpret that.
Yes, that's so the way we defined history of pain, and I should have probably clarified when I was talking, it was and I'm just scrolling because I know I have that in my notes in this slide. So it was if the patient had hospitalization and or ED treatment release visits requiring IV opioids for pain in the last 3 years.
Okay, that's great. Thank you. And the last question that I'll ask, and then I'll turn to the questions that are coming in, is and this is something we've started looking at some of our SCDC data in relation to COVID, and one of the things that comes up is sort of the different eras of COVID. So you have the pre-vaccine era, and then in the post-vaccine era, you have Delta, and then you have Omicron as well. And I wondered if in any of your studies, I know you did show the dates, but if that was a consideration of making sure that you did everything based on essentially the alpha version of COVID, or and whether the registry data actually you might be starting to look at some of these other eras of the disease as well.
Yeah, we've spoken about that in our group. Well, at the time that we did the study for which I presented data, we used only data starting March 2020 until March 2021. So that was still the first year of COVID-19 when vaccinations were not as widely available. But yes, future studies on how we account for various waves, various variants, and whether the individual has received vaccination or not is it's still a question that we talk about in our group. But interestingly, what we have seen from the data in our registry, and if you don't mind going to slide number, I think it was 30, please. I can. 30, sorry, the one with the graph for cases submitted. Yep, that one. One back, please. This one. So if you see over time, I mean, when we started the registry, there were suddenly more number of adults that were being reported, and over time we actually have more pediatric cases reported, and it's hard to know whether that's just reporting bias,
Right.
or if it is availability of vaccines for the adult population. But yes, I think future analysis will need to carefully consider how we handle that.
Yeah, that's a great point. You
The
really
timing
see the question there in that graph. Okay.
Yeah.
Okay, let me start with a few of the questions that are coming in. We really appreciate your taking some time to answer these. It's always an interesting bunch of questions after these webinars, and other folks are, you know, if you want to weigh in, not necessarily ask a question, you are welcome to do that in the question box as well. So the first question is, how do providers know to participate in the registry? Who are the providers participating in the registry? Is it a particular network? Is it ASH or some other network? And how are you spreading the word about that?
So that's a great question. First of all, I mean, any provider who takes care of sickle cell disease patient and who sees a COVID-19 case can report that onto our registry. So it's not limited to any specific set or network of providers or members of specific society. Regarding the dissemination, ASH had American Society of Hematology had set up when they started to set up their COVID-19 registries for various heme conditions. They included secure sickle cell, the link to our registry for sickle cell disease population in there, and there's no duplicate source of COVID-19 registry for sickle cell disease patients in there. So it's just, so if you go onto the ASH platform and look at the registries for COVID-19 and sickle cell disease, secure sickle cell disease registry, there's a link to the secure sickle cell disease registry. And there are other registries that are for other hematology conditions and as such. And we also presented at various platforms at national and international level to spread a word about this registry when we created it, and when we had some data, and I think it was a combination of that helped create awareness about this registry. And also we collaborated with the CDC to publish a report that's about the cases reported to secure sickle cell disease registry. So I think all of that collectively helps spread the word.
Thank you. It sounds like it's wide-reaching, and you're continuing to collect data. I assume there's not an end date at this point.
Correct. Yes.
Yeah. We have lots of great questions coming in. A couple of them are, I think, maybe more for providers than researchers. So let me focus on the ones that are about the data that you presented first. So Dr. Kale asks whether you took into account hydroxyurea utilization in any of the analyses that you worked on, whether that might be a variable, in particular because you have that one graph that shows that the majority of patients in the registry had mild or asymptomatic COVID. She's wondering if hydroxyurea may have played into that.
Yes, so we did collect in our registry, we do ask the question about whether the patient's using hydroxyurea or not. And when we are looking at risk factors for hospitalization and severe COVID-19 illness, we did include hydroxyurea as a variable, but that was not significantly associated. That was not a significant factor in contributing to the to requiring hospitalization or severe COVID-19 illness.
Oh, okay. So not in the severity or in the hospitalization.
Yes.
Okay.
So we included that in our yeah. We looked if there were any associations with hydroxyurea use and severity of COVID-19 illness, but in our data to be the case.
It's really interesting to know. And then I'm going to combine two other questions. Does the registry have data on, and if so, are you able to discuss it? Any information on reinfections and on the effect of vaccines in terms of severity or outcomes?
So exactly for to be able to study those questions, we've added those questions. The question on vaccination was added in June of 2021, and questions on reinfections added in November 2021. We've not analyzed the data on how that impacts the severity or the need of hospitalizations for sickle cell disease patients who get COVID-19, but that certainly is a very interesting question that we want to look at in the near future.
Thank you. A couple of questions that are more about care and outcomes that I'm not sure are in your data. One was if you looked at the treatment received for COVID inpatient or outpatient patients and whether that may have had, and I assume that would be things like antivirals or early on assistance with breathing or those kinds of things. Are data on those kinds of interventions included in your data?
Yes, it is. I think we collect information on whether patients received azithromycin, corticosteroids, heparin, or remdesivir. We have not looked at the effectiveness of these therapies on COVID-19 outcomes.
Mm-hmm. Okay, and that, but we're going to have these data for a while, so I assume that may be in your plans for the long term.
Yeah, I think so at the time that we published our paper on risk factors, it was just 1 year into the registry. So that time there was not as much variability in the treatments received, and yeah, so we did not include them in our models because we wanted to the patient level risk factors, not patient level and sickle cell disease related risk factors for hospitalization or severe COVID-19 illness.
Thanks. And then I think you've answered a lot of questions, very much appreciated. I'm going to finish up with just one last question for you. And that is about long COVID for sickle cell disease and whether that's been something, first of all, whether you've looked at the incidence and the incidence of long COVID in this population with either of your data sources, and then additionally, whether, if so, whether what the symptoms are, what the outcomes are of long COVID are any different for those with sickle cell disease than for the general population.
Yes, so we don't include long COVID in our registry as just yet, and for the very reason that it's the definition of long COVID keeps changing.
Yeah.
But we within our group we think it's a very important question to investigate long COVID and how COVID-19 impact sickle cell disease related complications, even if it's not how long COVID is described for the general population. So yeah, those are good questions, but I don't have the data to answer them. But yes, we don't as of now, we don't have that in this registry, but we certainly can look at it using other data sources.
Yeah, thank you. I know as we start to look at these data, you realize how much is unrecorded and how much is unknown, or at least in the data that we have. You know, it's such a novel disease. Even now, 2 years into the pandemic, there's still so much that is either just not known, or I think more relevant for the kinds of work that we do is not being recorded in the data. And so that makes it really hard to investigate.
Right.
And I think long COVID is one of those things that that is just, it's not coded consistently, and it's very difficult to tease out of these kinds of big data sets. So
yeah, and I know some other studies outside sickle cell disease, they define long COVID as if a patient has a visit to a long COVID specialty clinic, but we know the disparities faced by the sickle cell disease population. I don't know if that's applicable for our population of interest.
Yes, excellent point. I'm going to stop there and just thank you once again for sharing so much of what you've been doing with your data and helping us think about this problem and the pandemic and how it impacts the community. And just a real appreciation for you being here today. Thank you so much.
No, thank you for giving me the opportunity to talk about our work. It's my pleasure.